educators in the U.S. And I've gotten to know him quite a bit over the years as a friend also, which has been wonderful. After graduating from Frost University in Maryland with a degree in mathematics, which in and of itself is impressive. Everybody I've met who has a degree in mathematics is usually brilliant. He then went to Vanderbilt where he got his MD degree, started his residency there for the first 2 years, and then moved to Baylor in Houston, where he finished his residency, went into private practice, but then became realizing that he needed to teach because that was what he was to his core, and grew up with parents who were teachers, and got only 35 teaching awards while he was at Baylor. And this was noticed in Boston. In Boston, at Mass General's program did something very unusual. I was there in residency, and pretty much you got on faculty at Mass General because you somehow came up as preparation H. Harvard undergrad, Harvard Medical School, Brigham, or Mass General residency. And they reached out and snatched Dan from Texas to lead their inpatient medical education program, which was the teaching service of the residents. And there he won multiple awards, including the most prestigious Cranes Teaching Award, and then was also given an award by Harvard for the Best Clinical Instructor Award. And finally, the Society of Hospital Medicine gave its highest teaching award, the Award for Excellence in Teaching, back in 2011. And then Emory reached out. They realized they needed desperately a new head of their program after losing a third of their hospitalists in 1 year. And he came there, took over the program, and grew it to now they have 265 hospitalists, another 35, 40 advanced practice clinicians at 9 or 10 hospitals now? 10 hospitals. So it's the biggest academic hospitals program in the United States, and they've got a very robust scholarship. Our hospitalists learned about this yesterday. And there, no surprise, he won the Golden Apple Award, and he won the UHA-COCO Teaching Award, the most prestigious teaching awards in the internal medicine residency program. So I'm really looking forward to his presentation today so I can learn. Thank you.
Mark, thank you so much for that introduction. Let me tell you a little bit about the teaching awards before we really get into this topic. The first award I won at Baylor, I called my little brother, who is an academic general internist at UAB. And said, Steve, guess what? I won a teaching award. It's like, damn, there must not be any teachers at Baylor. Yeah, well, that's what little brothers are for. Okay, we're going to talk about a topic that Mark Williams assigned to me. Why the Division of Hospital Medicine is essential for a successful academic medical center. Dr. Frazier just put me very at ease by saying, we love hospitalists here. I was a little worried that I was coming in with an agenda. But this gave me a really good chance to reflect about our division and are we essential and how do we become more essential to an academic medical center. So I'm going to take you down a bit of a pathway here. I do have to give disclosures, a few stocks, randomly bought, not actually relevant to this talk at all. The objectives here are, let's talk about the history. And I think it's actually a good idea to remind ourselves of the history of hospital medicine as we think about the role of hospitalists in academic medical centers. And I'm going to do that partly through a lens of my own journey to become a hospitalist. I still at my core consider myself a general internist. Dominique, is that okay? I'm still a general internist. I'll always be a general internist. I miss the clinic, actually. Yeah, but I've become a hospitalist for a number of different reasons. We'll outline some contributions to academic medical centers, and I'm going to give you a couple of examples of major contributions that divisions I've been privileged to be associated with have had over the years. And then we'll consider some challenges and opportunities going forward. So let me tell you about me. Back when the earth was cooling, I went into private practice, as Mark said. Private practice with Kelsey-Seybold Clinic, which was a huge operation in Houston. It still is. I was based at an outlying clinic at Kelsey-Seybold West. It was about 15 miles from the Texas Medical Center where we admitted our patients. I stepped into clinic on that first day. Kelsey had just taken on HMOs. I stepped into clinic and there were 25 patients on my schedule. Sink or swim. How are you going to deal with that? But we needed to take care of patients in the hospital as well. So one of my partners, Dr. Kathy Ryan, and I decided that what we would do is spend half a day in clinic and half a day in the hospital. And we would alternate months in the hospital. And so I would be taking care of our collective patients on my months in the hospital, and she would be taking care of my patients on her months in the hospital. What were we at that point in time? We were half hospitalists. Actually, a lot of private enterprises were already figuring this out. So then I moved to Medical Clinic of Houston, and we think about some of the advantages of being in a traditional private practice. You know the patients. Those transitions of care are relatively easy. I'm telling my patient in the hospital, come see me on Tuesday at 8:15. I already know what's going on with that patient, and so those transitions are much more seamless. I enjoyed the inpatient and outpatient experience, and so when we've differentiated, we've lost some of that. I felt like I had a larger community of colleagues that I was interacting with when I was in that private practice environment. The disadvantages at that time were very long hours. It's one of the reasons I went back to academics, that the hours were very long in private practice. It was somewhat inefficient, and we'll talk a little bit more about that. It's a lot of knowledge to retain. If we put me into a general medicine clinic now, I would really struggle. But by the same token, if we put a general medicine doc who spends 90% of their time in clinic into the hospital setting, that may be a struggle too. We lost revenue to teach, honestly, in private practice, but we loved teaching, so we committed to it. And it was really tough to be in two or three places at once. One of the ways we dealt with that in private practice is when I admitted a patient, I tried to find a reason to consult nephrology. Yeah, they're in the hospital. Well, that's pretty cool. Or pulmonary, or ID, sometimes all three. It made it easier to be in clinic and not have to worry so much about what's going on in the hospital. Is somebody going to call me from a 15th floor of St. Luke's at 11:30 to let me know your patient is sick, I need your help right now, and I've got a backed up waiting room. So there were disadvantages to the practice model. We'll talk a little bit more about this, pulling some literature in. So there was some degree of disappearance. It began around that time. It was revenue driven, pressures to increase office volume, need to minimize length of stay. Anybody deal with that? I think there's some hospitalists over here. Y'all being pressured on length of stay? Have you solved it? Oh, thank you. I'm feeling much better about myself. We've been working on this for 35 years now. I have not figured it out yet. And we've got task forces in our division that are working on it right now. There are a lot of reasons we've had struggles with that. There were desires for more manageable lifestyles. The practice I was in, a year after I left the practice, hired its first hospitalist, having sworn up and down we would never have a hospitalist. I left, they hired their first. Every doc's income went up by at least $10,000 a year, even accounting for the cost of paying for a hospitalist. Increased demands of inpatient care. They're sicker patients. Are y'all's patients getting sicker? Ours are clearly getting sicker. And we are decanting some of the patients who are less sick to an outpatient environment. We are not doing hospitalist at home yet, but we may be asked to do that. And that's going to increase the number of patients who have increasing complexity in the hospital. Early concerns from the literature. These were great things to deal with if you were a hospitalist at the time. Dr. Williams, did you ever hear these things? No. Yeah, right. All hospitalist models interfere with continuity of care. Let's be honest, they do to a certain extent, and they still do. It's a challenge. Mandatory handoffs, at that point, this perspective said they're bad. Well, they're the reality, so we have to get better at it. Threatened the specialty of internal medicine. The typical internist hospital service is small, but hospitalized patients require more intensive effort, et cetera, et cetera. You know, I experienced this at MGH where I was on teaching teams pretty much a lot of the year, 26 weeks a year. I was sitting at the nurses' station, and one of our great primary care docs, Dr. Seward, sat down beside me. One of her patients had been admitted to the hospital with endocarditis, and we were taking care of the patient. And we started talking about the patient, and she said, you know, it's been at least 5 or 6 years since I saw a patient with endocarditis, maybe longer. At that point, we had 5 patients with endocarditis on our service. And it just impressed upon each of us, wow, there's a separation of expertise here and experience. Going on with the literature, at this point, it's very unclear how much of the hospital future will rely on hospitalists. Yeah. Huh. What do you think? Will hospitalists drive more expensive care? It's still an unanswered question to a certain extent because some of care is being shifted to the outpatient sector, and we've seen that in studies. So the overall care, I'm not sure we've answered that question. The inpatient care, I think we have answered the question. There are breaks in continuity. Will hospitalists honor patients' goals of care? We try. Will hospitalists burn out quickly? Let's see, I've been doing this for how many years? I don't think I'm burned out yet, but it's a big concern for our specialty, as it is for primary care, as it is for every specialty in medicine at this point. Burnout is a huge issue. Can hospitalists survive turf battles with subspecialists? Schroeder and Shapiro asked that question. What do you think? What were they thinking about? Maybe they were thinking that hospitalists were going to take away revenue from the nephrologist who's been caring for patients in the hospital or the pulmonary doc who's been caring for patients in the hospital. I would posit I deal with more of the opposite. Any of y'all hear about things like this? Cardiology comes to the division chief of hospital medicine and says, you know, we're kind of tired of taking care of patients with heart failure. Would you all take that on for us? Did that ever happen? Oh, yeah. I deal with that regularly. And my response is, show us the money. In part. There's some things that we have decided not to take on for various reasons. Will hospitalists mess up medical education? Dr. Costco, have we messed it up? But that was a concern, and it was particularly a concern, and it's still somewhat of a concern. You had experienced generalists who were attending on services, and now, for the most part, we had hospitalists with relatively lower experience who were suddenly attending on teaching services. Positive consequences: short length of stay, enhanced standards of inpatient care, emergence of hospital medicine as a career choice. We had 13 Emory senior residents apply for positions with our division this year. We don't have enough positions for everybody. That's a great thing. Dr. Williams says, send them to St. Louis. Okay, well, give me some brochures. We're competing with systems in Atlanta that compensate generously more. New cadre of journalists, clinician educators in teaching hospitals, and we've had to learn how to teach in that environment. And it meant primary care, practice transformation, and establishment of medical homes, et cetera. Adverse consequences for primary care, we've covered some of these already. Loss of control, worry about redundant or unnecessary testing, that's been a big issue, and we can continue to see that issue. I understand you all have had Epic for 5 years, is that right? Has it solved the problems of getting the test results from outside institutions? It's better. Yeah, it's better, but it's still not great. Lack of coordination, high rates of readmission, complications, atrophy of the inpatient skills, and as I was confessing earlier, atrophy of my outpatient skills. I would have a really hard time in an outpatient clinic. And social isolation, it's actually a concern for hospitalists who are rounding on their own cadre of patients, but are not interacting as much as you would be in a primary care practice, although it's not that different in some ways. So complex environment, increasingly complex patients, we covered that, needing to address difficult issues, and so I sort of summarized a number of these things in this table. Focus skills in inpatient medicine, we get better at it the more we do it. There are advantages, we're available in the hospital. It's not that problem I was mentioning earlier where I'm in clinic and I cannot get to the hospital without dropping my clinical practice, and so that's a clear-cut advantage. Better inpatient supervision for resident teams. I actually neurosed about that supervision term this morning. I thought, that might be the wrong term to use here, where I suspect residents have a fair amount of autonomy. Is that correct? I see some nodding heads. Yeah. Well, I probably should have said graded responsibility is better for residents. Yeah, I'm not sure what the right term is there. Okay, and the disadvantages, we've touched on many of those. Okay, back to me for a few slides. Inpatient clinician educator, Ben Taub. And then suddenly we saw this rapid growth of the need for hospitalists. And what drove that? The shift to outpatient ambulatory training in part drove, we no longer have an intern for every single patient admitted to the hospital. And so now we've got to think about how do we take care of those patients. There were caps on teaching teams. Is that a bad thing? I'm asking residents about that. No, it's a really good thing. Yeah, because we can focus more on how we're learning with each of those patients we're taking care of and providing good care for those patients. So that was a good thing, but it means some of those patients are now shifting to direct care hospitalists. Work hour restrictions impacted things. We were exchanging notes about our training programs last night, and I had a whole lot of every other night call. Thank goodness that went away. That probably damaged me forever. There's a growth in clinical demand. We've talked about the complexity. There was the exit of non-hospitalists from the hospital, and that's an ongoing trend, even among our subspecialists at Emory. And there's a desire for co-management. Anybody have orthopedics come to you and say, yeah, we'd like to have you manage our post-operative patients? Yeah. So this is what happened. Rapid growth of hospitalists. And we're probably well above 60 to 70,000 hospitalists in this country at this point. Back to me for just a second. And Mark mentioned Mass General came calling. And I'll be honest with you, I thought there is no way Mass General would ever take me to build a clinician educator service. But I was fortunate to have that role, and so we built a dedicated inpatient teaching service and learned how to teach in that inpatient environment, did a lot of professional development within our group. And then, this is one of those things, I'm sitting in a med exec meeting, and Denny Ociello, who was the chair of medicine at that point, turns to me and says, I think it would be a good idea to bring together the clinician educators and the direct care hospitalist service. Don't you think that's a good idea? What is the correct answer? Well, I knew what the next question was going to be, so I said, yeah, that's an interesting approach. And he said, I want you to lead that. Ooh. Well, okay, I'll try. So we actually brought those two services together in a lot of activities at Mass General and built a big service of direct care plus teaching. So Mass General, oh, I got to go back to that one. It was about that time that I was in an SGIM meeting, Society of General Internal Medicine National Meeting. I think, Dr. Williams, I might have been sitting next to you during this plenary session. Plenary speaker gets up and says, hospitalists are nothing but glorified PGY-7s. Yeah. Yeah, so me being me, that's what I put on my name tag. And I walked around the meeting with that name tag for the entire meeting. I'm in my 50s. I kid you not. I had folks walking up to me saying, where are you doing fellowship? I'm like, look at me. I would be the oldest ID fellow in history. But that was kind of how things were thought of at that time, and there's still some degree of that. I still see that even in our division with some of our folks who are relatively junior, taking care of much more senior and experienced physicians' patients, and there's still that sense of I'm being treated like a resident. But we're getting past that. So the drivers for the increase, teaching became much more of an issue at Mass General. Clinical care with increasing complexity in numbers, but were we academic enough? And I'll talk a little bit more about that. I did a quick PubMed search to look at how many papers have been published over the past few years that are linked to hospital medicine. It's increased, so that's encouraging. But are we essential? Anybody recognize that image? Marathon bombing. I get a call from my partner, Alberto Puig, who is attending on our ED border service at Mass General. Alberto could tend to be a little bit hyperbolic sometimes, but he says there's been an explosion. And I said, an explosion of patients in the ED? No, there's been an explosion. We're expecting 30 ambulances. We have to clear the ED as fast as we can for trauma surgery to take care of incoming casualties. We don't know how many patients are coming. And hospital medicine stepped up to say, we're going to take care of this. And so we were triaging patients out of the ED. We were triaging patients upstairs. We were clearing beds. We could not have dealt with that in any other way. And it was a convincer of the value of hospital medicine in a clinical crisis. And I'm going to come back to some other clinical crises in a few minutes. So if we don't think we're essential yet, I'm going to have to do some more convincing. 2015, as Mark said, I had the privilege of coming to Emory to lead a large division of hospital medicine. At the time, it looked like this. We've now doubled in size. We're big, we're complicated. We've got hospitalists in 10 different sites around Atlanta. These are the 8 major sites, and then we have small operations at an LTAC and an orthopedic and spine hospital. We have a large leadership team, and I actually showed this in the presentation yesterday. We're particularly proud of the diversity of our leadership team that we've worked hard on over the past 9 years. And the reason I'm able to be here and keep my pulse rate under 100 is because these folks are taking care of everything, and it's awesome. This is what we look like, and it's going to point out a few things that are important to note. So we take care of a lot of patients, we run a lot of teams, but how many teaching teams are we attending on? Relatively small number. And so that impacts how we recruit for academic hospitalists. And in fact, you're probably not going to have a lot of time on teaching services. In fact, at some of the hospitals, you're not going to have any time on a traditional teaching service. By the numbers, this is what's happened over the past few years. Give anybody headaches? Rapid growth, and I suspect you all have seen the same thing here, rapid growth in terms of patient encounters. So, and that does not account for our VA operation or our Grady operation. I took a snapshot of a typical day, and this is very typical for us. We're caring for almost 1,000 patients in Emory Healthcare on any typical day across our sites, and it's a large percentage of the hospital volume. So are we essential? Oh yeah, we're essential. At Grady, so our Grady operation began 6.5 years ago, and it began when the house staff services were overwhelmed with clinical volume. And our administration came to us and said, we would like to have direct care hospital medicine at Grady. And we thought, we don't need the business, so we're going to make a proposal that there's no way will ever be accepted. Turns out it was totally accepted. And we went from a summertime start of 30 patients on that service to January, we had 120 patients on that service. And Dr. Joanna Bonsall has done incredible work operating that service, managing that service, leading them to a very successful operation at Grady. But are these patients, there's a lot of patients, but are they the right patients for us to be seeing at an academic medical center? And this study out of UCSF is actually trying to answer that question. It's saying, are these patients we're caring for actually patients that we would typically want to have in an academic medical center? And it's making the argument that the majority of their patients are actually patients who typically are either followed in a subspecialty clinic or in a uber subspecialty clinic, ultra subspecialty clinic. And yes, those are the patients we want to see. Now at Emory Healthcare, we're now in the process of standardizing our transfer activities across the entire system to try to enhance the number of patients we're bringing to Emory University Hospital who need transplants. And that's going to impact us directly. I actually saw some numbers a couple of days ago that showed that outside transfers into our system total for a year and a half, 9,000 went to hospital medicine. The next highest was cardiovascular care at 3,000. We are essential. Oh, that brings me to this. Any of y'all deal with this, the C-suite? Yeah, we have a complicated matrix where I'm reporting to a C-suite, and I'm reporting to the department chair, and I'm reporting to the dean. But what does the C-suite want from us? This was actually an interesting qualitative study that looked at what do these folks want? Interviews, and the thematic analysis here was they want clinical excellence. They want a capacity to collaborate with hospital leadership, scope of services provided, cultural fit, financial performance, contract cost, pay for performance measures, turnover. I don't see peer-reviewed publication. That is potentially a problem. But let's find out. I pulled out some quotes from this paper. If you're just coming in to fill a shift and see 10 patients, man, I really want to know where that CMO is based. Yesterday morning, our teams at Midtown were seeing 16 to 18, higher than we'd like to see. But the important point here is involvement in other activities in the hospital. So quality improvement projects, major initiatives, engaging with nursing staff, et cetera. If we have the right hospital staff to engage them with the nursing staff would help reduce my turnover rate. I'm going to make a point that's somewhat tangential here. I would change my to our, subtle but important. But anyway, the point there is the positive morale of nursing is incredibly important to our hospitals, and it's particularly important now when we're competing for nurses in an Atlanta market that is very competitive, and we're trying to reduce our reliance on contract labor. Oh, and here's my personal favorite. Anybody want to have a urologist use a stethoscope? I'm trying to think what they'd use it for. Maybe a brewy over something. I don't know. But it's emphasizing the role of hospitalists in caring for patients who are medically complex, who are having major procedures in our hospitals. Can we combine what CEOs and chairs of medicine want? And here I'm on a little bit shaky ground with Dr. Frazier's in the audience. I've got to be careful. But can we combine it? And so I'm going to give you a few examples. And so this is actually a study that our group did on reducing telemetry utilization, which was a major issue for us. And we ended up being able to publish that. It's fulfilling multiple missions. And I pulled out one of Mark's papers. I don't know why I chose this one, but it's an example. So we're doing things that are important in terms of operations, but can we turn that into scholarship? And then I love this study. What do y'all think? If you prioritize rounding early on the patients who are going to be discharged that day, does it help? Is that personal experience or evidence? Both, correct. This was actually a provocative study that looked at this question and said it did not make a difference. Wow, that's a cool study. Now, I'm still trying to convince the C-suite that it's legit, but anyway. So our hospital medicine division is fulfilling the academic triple mission. Research is a small balloon for us at this point, but we're trying to grow it. And I think that's true of many divisions around the country. The state of research in adult hospital medicine, these were updated results from a national survey. And it turns out there's not a lot of research going on in hospital medicine, but there are pockets of excellence, and you're developing one here. And so, yeah, the things that we do are not typical research, but as this table is pointing out, the majority is health services research, outcomes research, and essentially operational research or implementation science. And so we're trying to go down that pathway. We are not likely to be involved in a lot of basic research, but we have major contributions to make in terms of our scholarship. Oh, this one made me feel better in some ways. I didn't show the slide I showed yesterday, which showed my journey to my first publication. Took how many years? It was actually 14. Private practice does not compel you to write papers, I'll put it that way. And so this was an interesting study to say, for hospitalists, when we look at their PubMed citations and we compare years in practice, how much scholarly productivity is there? So it turns out the median number of publications was 0. That's disheartening, but it's an opportunity. We can enhance that. And faculty 6 to 10 years, and up to 1 publication median. So it's a challenge, but I know from our conversation yesterday that y'all are ahead of that challenge. And from looking at the website, which is really impressive here, overall for the Department of Medicine. And we're still struggling to get more advancement in academics. And that's emphasizing that here in this graph. So scholarly productivity and growth of academic hospital medicine, full professors. Same sort of curve. It takes a while. And it's primarily because we are so focused on the clinical mission and we are focused on the educational mission, but really we're focused on the clinical mission. If you're grant funded, the curve goes up better, but it still takes time. and that's similar in this. So I'm going to talk just briefly. Our division has made this a priority in terms of scholarship, and this is a table showing our progress over the past few years in scholarship. But as we pointed out yesterday, it took us a while to get started. And Zach, I think you pointed that out in a question that we had yesterday. And so it takes a while, but we can do it. How about education? Another interesting study. And I can tell you the majority of folks we are interviewing really want to be clinician educators. It's what we see when we're residents, and we really want to do that job. So that's exactly what this quote is giving us. And so we're struggling with that to a certain degree in our division, that we, as you saw earlier, we don't have enough teaching slots to satisfy everybody's need for teaching. So we can talk about how we've approached that. And so there were some solutions proposed in this table, which I think is useful, and particularly looking at other extensions of our learners, definitions of our learners. In our division, we have taken the approach of saying we do not want to be dependent on the School of Medicine or the residency program for our culture of scholarship. And that's very intentional. It's to say we can own it. We need to be building our own scholarship, building our own culture of continuous learning within the division. All right. Oop. Last few slides, leadership. And this has been an important thing for us in our division, and I already know y'all have an associate CMO coming from hospital medicine. Awesome. Leadership. We as hospitalists are in the hospital, we're connected, and so I'll give you examples. In our group, we have multiple small group advisors at the medical school. They competed very well for those positions. Associate Core Clerkship Director, Audrey, has done terrific work in that space, probably will be the next Core Clerkship Director for internal medicine clerkship. Transitional Program Director, Monpreet, has done terrific work in that. Rena Himmerjani has done amazing work as the Program Director, which now reminds me, I also report to Rena. Wow, this matrix has gotten even more difficult. It turns out Rena has her career conference with me coming up in a couple of weeks. How's that going to go? It's going to go with 5 minutes of me telling her how wonderful she's doing and 55 minutes of her telling me what we should be doing as a division. That'll be great. We have hospital leadership roles, major leadership roles, and we've worked into those. And so, yeah, this is actually a little bit out of date. Sarah DeCaro is now the System Director for Emory Healthcare for care coordination across the entire system. Amazing work. And so many of those things are important to a division of hospital medicine for respect in the hospital and in the system. Do they get you promoted? I don't know. If I talk to most of the folks on this slide, they'll say, not a priority for me. I love what I'm doing. Is a division of hospital medicine essential for a successful academic medical center? Have I answered the question? What do you think? Yes? Only a few yeses. Okay. I'm going to tell you another story. Grady had a flood. A pipe broke on the 5th floor, a 12-inch pipe. There was water cascading down through the ceilings of multiple wards. What happens now? We have to evacuate those wards. We have to figure out where those patients are going to go. We have to figure out how we're going to deal with this over the next 12 months as we rehab those wards. Hospital medicine stepped in immediately to take care of that situation. And our hospitalists at Midtown stepped in immediately to say, we can take patients. And so, are we essential? Absolutely. This happened to all of us, COVID. I don't know about you all, but hospital medicine was on the front lines of COVID. In fact, volunteering to be in our ICUs, during the early COVID months, and taking care of at least half the patients admitted to the hospital with COVID coming out of the ICU. And although we did not advertise it widely, Emory Healthcare actually had the second lowest mortality for COVID patients admitted to the hospital in the country. And a lot of that had to do with hospital medicine adapting rapidly to the situation. Anybody remember Mpox? Yeah, briefly. We were panicked a little bit about that too, but thankfully it didn't evolve to a huge issue for us. But then we dealt with these issues. COVID influenced our financial situation, as I think it did most academic medical centers. And we've had to deal with that, and we've had to adapt to that. And we're finally coming out of that. And then we implemented EPIC. Anybody enjoy going through implementation of EPIC? Yeah, we are now emerging what is sometimes referred to as the Valley of Despair. We're now 18 months into it, and I think we've made a lot of progress, but we got a lot of progress to go. And then we had another event happen that Wellstar closed Atlanta Medical Center, one of 2 level trauma centers in the city. That put any pressure on the other systems? Oh yeah. Did hospital medicine react to that? Oh yeah. In fact, our group at Midtown was dealing with 60 patients waiting in the ED for beds, and they're still dealing with that on a not infrequent basis. And so are we essential for the academic medical center? Absolutely. And then we've had leadership changes, and we're dealing with that at this point. To the positive, but we're dealing with that. Thank you. I actually prefer having conversations, so I'd love to have questions or comments at this point. Jen.
Can you talk a little bit about how hospital medicine and general medicine interact and how they work together? Since, hospital medicine kind of organically grew out of that general medicine group. So thinking about like recruitment and kind of dividing up the work, how do you do that at Emory? Leave them together.
Yeah, so it's a complicated question. So how do we deal with the interaction with general internal medicine and hospital medicine, in particular at Emory? So specifically at Grady, when we go back to the issues of overwhelming clinical demand, the model for general internal medicine was more the traditional model, and it still is, of attending on teaching services, both inpatient and outpatient. And there really, honestly, was not an appetite to take on the direct care service. It's a big undertaking. And so our interaction was a little bit rough at the start, and so it's smoothed out a lot. And there's been the recognition of the value that hospital medicine brings to that operation. Across Emory Healthcare, it's interesting, when I was being recruited to be division chief, the chief of general internal medicine was one of the interim co-division chiefs for hospital medicine. And Ted was very delighted to see me show up, because it's a huge primary care network, and it's a big operation to run. And so our interactions with primary care are really hospital specific. So at EUH, we have really tight interactions with a large primary care academic group, and there's a lot of communication back and forth. At St. Joe's, for example, it's much more private practice oriented, and we've done some things like concierge. It's the wrong term, but it's the term that's been used, is direct contact with a hospitalist when you need to admit a patient, and direct admission with a hospitalist taking care of the patient, and a lot of interaction back and forth. So those have been really positive things. Could we do better in integrating the two or in collaborating? We probably could. It's a work in progress. I don't know if that helps.
Yeah.
Other questions or comments? Y'all are being too easy on me.
Hi,
Hey,
I'm Ben. I'm a hospitalist here, and I just finished. I am residency program here. My question for you is, you talked a little bit about the turnover rate of nurses and how important that is to consider when talking about hospital operations. But wonder what your thoughts are on the turnover of hospitalists. In that it seems like a lot of my colleagues in my residency class, some of them would go and do hospitalist for a few years as a transitional period before applying to a subspecialty. And so I wonder if you would comment on how you're thinking about recruiting and retaining hospitalists for the long term.
Ben, I love that question. So how do we think about recruiting and retaining hospitalists in a setting where, in fact, some people are looking at this as a transitional couple of years before fellowship? So I'm going to answer this in a lot of different ways. First of which is we have co-associate division directors for recruitment, onboarding, and retention. One of the best things we ever did as a division since I got there, because I'm no longer having to review 300 CVs to decide who we're going to talk to. They've done great work in thinking about how do we recruit appropriately and retain. Mark mentioned early on that the turnover rate for the Division of Hospital Medicine at Emory, the 2 years before I got there was 33%. 1 year before I got there was 25%. I'm not sure that was actually revealed to me when I was being interviewed. I found out later. Our turnover rate this past year was 5.4%. Much of our turnover actually is driven by partners who get a job in a different city. And try as I might to say, it's not that hard to commute from San Diego. That argument's just not winning. So we're turning over some in terms of you need to move for family reasons. We are turning over some in terms of fellowship, and we probably have had, I think, 3 folks who are leaving for fellowship this summer from our division. We actually have taken the approach now in the past couple of years of saying, or particularly in this year, saying, if it is obvious that you are headed toward fellowship, and for anybody who's in the audience who's a resident thinking about applying, if you've got a whole lot of publications in cardiology, it's going to be good luck to you convincing us that you're not headed toward cardiology. But we have roles that we think are really important to fill that are challenging for us to fill. And so you may spend half your time as a nocturnist. That's all we're going to be able to offer. And so we're trying to go down that pathway of really specific roles that would fit well for what your career desires are, but they're not going to be enhancing your long term. Now, the things we've done as a division to try to enhance, and I could get into this in a lot of detail, is building internal programs that you say, you know, I really like this. I'm not going to leave this. And that's been a key for us, is having those things go on within the division where we get excited about the things we're doing. And we've had folks who've said, I'm not going to do fellowship now. I really like what I'm doing. I don't know if that helps. Yeah, commit to it for the long term. All right, other questions or comments?
I have a related question.
Yeah.
So you mentioned you had 13 applicants internally from your residency program, which is fantastic. With the kind of lower amounts of teaching times that are available at your various sites, how does that inform your recruitment of your own residents?
Yeah, so the question is, how does it inform our recruitment when we know we have less teaching time at various sites, and including if you're going to be at EUH, you're not going to be on the teaching service very much. So we're very upfront about that. And in fact, we will say to applicants, and I'm saying this in each of my interviews, you will not be on the typical resident teaching service in the first year or maybe 2 years. We're doing that for a variety of reasons, one of which is we don't have enough space. But the second is it's going to take some time to get clinically good at this. And then you're going to be facing senior residents who might have been a junior resident on a team you were on, and they're going to look at you and they're going to say, I don't believe a word you say. So I dealt with that a fair amount at MGH, where we did recruit a few folks right out of chief residency and right out of residency. And the two folks I'm thinking about had a very unfair advantage. They both had photographic memories. It was hard to compete on the wards with them, but that's unusual. And so we're saying, this is not likely to be part of what you do in the first couple of years. You can evolve into it. Here are the other things you could be doing. We have medical students who need preceptors for physical diagnosis. We have activities at the medical school that you could get involved in, half-day seminar series, et cetera. And within our division, we feel it's incredibly important for us to do our own professional development activities. So each of those sites have their own lunch and learn series, M&Ms, journal clubs, et cetera, that they're running for the sites. And that gives you the chance to be teaching, dip your toes into teaching, do it well, and then division grand rounds, and then Southern Hospital Medicine presentation, and then national presentation at SHM's national meeting. I'm really proud of this. We had 15 presentations at the national meeting this year from Emory faculty. And I'm even prouder of the fact that I wasn't involved in any of those. I could sit in the back and say, isn't that awesome? So we're trying to move the needle in terms of teaching. There are other ways that we define teaching. Does that help? Dominique?
Add that, showing all the names and pictures on the screen, that greater than 50% of people in leadership roles within division were residents at Emory. And so I think it also sort of illustrates that there are many different ways to be involved in academics and in leadership roles, and that you can clearly show that residents who are joining the division have, opportunities to reach leadership roles, because so many of those leaders were residents that, I had the experience of being able to teach and interact with.
Yeah. I think your mentorship probably had something to do with that. But that's great. And our residents do see that. They see there is going to be this opportunity. And particularly at Grady has been particularly supportive for us in terms of medical directorships of floors. And that's a really good stepping stone. If you get 20% protected time to be a medical director, don't turn it down. But that's been a leadership role that folks are now well integrated into the hospital, and they're driving quality improvement projects. It's been amazing to watch that. Other comments? Yes?
Hi, I'm Carl. I'm a third-year internal medicine resident here. I thought I heard you say that you were working on the process of more effective transfers into your facility,
Mm-hmm.
patients that were being handled by hospital service. My experience is limited to teaching services, obviously, but what have you found to be the best practices for patients who are transferred for or directly admitted by, say, a subspecialist service in internal medicine or in a surgical specialty, or are going to be admitted by a primary hospital as your teaching team? What are the best practices for making sure their care is efficient and things aren't missed? What forms of communication work best?
Yeah, so this is a work in progress. It's been a priority for Emory Healthcare of trying to make sure that we are getting the right person, right patient to the right setting with the right care. And this has just started over the past few months. With the change of leadership, it became a major priority. So the projects that are underway right now that hospital medicine is very actively involved in, we have a pilot of medical officer of the day for the entire system. And so all of the transfer calls are coming to that individual who's making sure that we have the contact with the subspecialist, that we can provide the care that we need to provide at that particular site in this particular time. It's a work in progress. The early results are very positive, and in fact, it may be somewhat seasonal, but our border numbers this past couple of weeks have been quite low, and part of that has to do with we're moving patients from the ED at Midtown to Emory Decatur, where there's capacity. But it's going to be an ongoing issue, and I was just in a meeting Monday morning talking about protocols for that, and we're actively involved in those protocols. Because there's nothing that makes a hospitalist more nuts than you accept the transfer, they end up in a bed on hospital medicine, and the surgical subspecialist doesn't see them for 3 days. That's a problem. And so we're trying to address those problems. I don't know if that helps, but this is a really big issue for us.
One last question, and Brad, you have your hand up.
Oh, yeah, this may be too long to answer for a short question. But what approaches have you taken to try to increase the research engagement and output by your faculty, and in particular for creating protected time for people to develop into independent investigators?
It's a long answer.
I can come down and hear from you.
I'll give you a short answer to it, that we are not a research division. We are a clinical division, and we stress that and we celebrate it. We are trying to increase our scholarship. So some of the things that we've done, we talked about yesterday actually in a presentation about clinical scholarship, and what we've done to enhance that within the division. Some of the most important things we've done have been have our own clinical vignettes, poster competition, our own research day. We have not funded a lot within the past 3 years because of the financial pressures on the system, but we're hoping to get back to that where we can fund individual projects at the 10 to 20% FTE range that are quality improvement projects that will help the system that we can then argue for more resources. And we've done some other things within the division of, we have our own research analyst, our own data analyst, our own research coordinator, who takes care of IRBs, et cetera. And I think one of the most brilliant recruitments we've made is we have a senior medical writer in the division who is amazing. Where has she been my whole life? Give her a manuscript idea and a rough draft, and it gets published. I hope that helps, but I'm happy to give more detailed answers. Thanks for having me.